Welcome to the deep dive. Today we're really getting into slipped upper femoral epiphysis, SEEE, right?
Exactly. SEEV. It's a really key topic in adolescent hip disorders.
Absolutely. So if you're prepping for exams, maybe the MSRA, or just want to get a solid handle on pediatric orthopedics, this is for you.
Yeah, our goal today is to pull out the really essential stuff from our notes on SUFE, make it clear, memorable, maybe use some mnemonics to help it stick.
Good plan, because, medical info can be a bit much sometimes.
It really can, so we'll aim for a focused, high-yield look.
Okay, let's start unpacking it then. Slipped upper femoral epiphysis, what exactly is happening there?
So fundamentally, SUFE is about the growth plate, the physis, right? At the top of the femur, the thigh bone.
Right, the growth plate.
Yeah, it weakens. And because it's weaker, the femoral head, the ball part of the hip joint, it actually slips off the neck of the femur.
Slips off.
Okay.
And this is mainly in adolescence.
Primarily, yes, during that period of rapid growth.
Got it. Now, our notes mention different ways it can present. Clinical groups.
Ah, yes. Good point. So you can have a pre-slip. That's where you might see changes on an X-ray, like the growth plate looks a bit wide, but no actual slippage has happened yet.
Okay, like a warning sign.
Kind of, yeah. Then there's acute SU. That's about 10–15% of cases. It's sudden, often quite severe pain and slippage.
Ouch. Sudden onset.
Then you've got acute on chronic. This is where someone already has a slow, gradual slip happening that's chronic SU, and then they have a sudden worsening, an acute event on top of it.
Right, a sudden deterioration.
Then the most common type, around 85%, is chronic SU. This is a slow, gradual slippage over time. Symptoms might be milder, maybe come and go.
Okay, that's a helpful distinction. Chronic being the most common, and then there's stable versus unstable. What's the key difference there?
This is really important clinically. So stable SUFE, that's about 90%, means the patient can still walk. They might have pain, they might limp, but they can bear weight.
Okay, they can walk.
Crucially, the risk of avascular necrosis, or AVN, where the bone tissue dies off from lack of blood, that risk is lower in stable cases.
Lower risk of AVN if they can walk. Makes sense. And unstable.
Unstable SUFE, the other 10%, is when the pain is so severe they cannot bear weight on that leg at all.
Okay, non-weight bearing.
And in these unstable cases, the risk of AVN is significantly higher. It's a much more urgent situation.
Right. That ability to walk is a major dividing line then. And the notes also mention grading the slip radiographically. Mild, moderate, severe.
Yeah, that's usually based on how much the femoral head has slipped relative to the neck. Often using something called the Southwick angle. It helps, guide treatment and talk about severity. Mild is grade the first, moderate to severe 3.
Okay. Useful for planning.
Yeah.
So let's talk cause, the etiology. Why does this actually happen?
Well, the frustrating thing is the exact cause isn't fully known. It seems to be multifactorial.
Multifactorial, meaning multiple things contribute.
Exactly. It looks like an interplay between genetic factors, definitely hormonal changes, especially around puberty, and mechanical factors.
Mechanical, like obesity.
Obesity is a big one, yeah. Also things like rapid growth spurts. All these factors are thought to kind of converge and affect the strength of that growth plate, making it susceptible to slipping.
So hormones, body weight, growth speed,
Right.
all potentially playing a role in weakening the physis.
Precisely.
Now, for risk factors, our notes have this mnemonic, obese hormonal growing pain. Let's break that down.
Yeah, it's a pretty good one for recall. So O is for obesity. Definitely a major risk factor. More weight means more stress across that growth plate.
Makes sense. B.
B is for boys. It's more common in boys than girls, maybe a 2.1 or 3.1 ratio.
Okay.
E stands for endocrine abnormalities. Think things like hypothyroidism or kids getting growth hormone treatment, hypogonadism, even panhypopituitarism. These hormonal issues can directly impact the growth plate.
Right. Underlying hormone problems. What about the second E in obese?
That E is for earlier medical history. Things like having had pelvic radiation before or chemotherapy. Also, renal osteodystrophy, which can cause bone dysplasia.
Okay, so previous treatments or conditions affecting bone. And the S.
S is for septic arthritis, specifically if it was neglected or poorly treated. An infection in the hip joint can weaken things.
Got it. Okay, that's obese. Now, hormonal growing pain.
Right, so hormonal changes. This really emphasizes the impact of normal puberty hormones, even without a specific endocrine disorder. That whole period involves hormonal shifts that affect the physis.
Okay, so puberty itself is a risk window.
Definitely. Then O, older age range, typically that 10 to 16-year bracket.
Right, the typical adolescent window.
R is for rapid growth. Those adolescent growth spurts put extra mechanical strain on.
The growing part, basically.
Exactly, growing. And M is for mechanical factors, which can include local trauma, though often it's minor or maybe not even recalled.
Okay. And then we have O again.
Yeah.
Opposite hip involvement.
Yes. Contralateral SUFE. It's quite common, especially if the child presents young. Maybe 20% up to even 80% in some studies, though that higher end seems a bit much. Big debate about whether to prophylactically fix the other side.
Prophylactic pinning. Yeah, I've heard about that.
And interestingly, losing weight after surgery, getting below the 95th percentile, seems to lower the risk of the other side slipping later.
That's interesting. Weight management again? What's N?
N is for nutritional deficiencies. Vitamin D deficiency has been implicated.
Okay. And A?
A is for age again, reinforcing that 10-16 range.
Right.
L stands for lower height percentile. This is particularly seen in those with endocrine conditions who get SCFE. A lot of them are actually quite short, below the 10th percentile for height.
That's counterintuitive almost, given the link with obesity.
It is, but it points towards those underlying endocrine issues affecting growth overall.
Okay. And then growing we covered, and pain.
Pain here circles back to pelvic radiation and previous septic arthritis, just reinforcing those as significant historical factors.
That mnemonic covers a lot. Obese hormonal growing pain. Useful. So, pathophysiology. We touched on it, but what's the mechanism of the actual slip?
It really comes down to that weakened physis. You've got shear forces acting across it, especially with weight bearing and movement.
Shear forces across a weak spot.
Exactly. And as we said, obesity increases those forces. Hormones like growth hormone and sex steroids during puberty seem to affect the cartilage cells, the chondrocytes in the growth plate itself, maybe how they multiply or mature. It makes the plate less able to resist those shear forces.
So it's a combination of the structure being weaker and the forces being higher.
That's the thinking, yes. And the result is the femoral head typically slips backwards and downwards posterior-inferiorly relative to the neck, causing that hip joint misalignment.
Okay. Now, differential diagnosis. If a kid comes in with hip or leg pain, what else should be on our minds besides SCFE?
Oh, definitely. You need to think about leg calvé-Perthes disease, that's AVN, but typically in younger kids.
Right, Perthes.
Developmental dysplasia of the hip, DDH, although that usually presents much earlier. Transient synovitis, very common cause of a limp in younger kids.
The irritable hip.
Yeah. And then more serious things you must rule out. Septic arthritis, an infection in the joint.
Urgent.
Very urgent. Also, maybe a traumatic hip dislocation, an acute fracture, or osteomyelitis, which is bone infection.
So a broad range from relatively benign things like transient synovitis to emergencies like septic hip.
You have to consider them all.
Okay. Epidemiology, how common is this?
Well, estimates vary a bit. Maybe 0.6 up to 4.4 cases per 100,000 kids per year, sometimes quoted as roughly 1 in 50,000.
So not super common, but common enough to be significant in pediatric orthopedics.
Definitely. Age peak is usually 10 to 15, maybe starting as young as 8. More common in boys, as we said, 2 or 3 to 1.
And left hip more often.
Left hip seems slightly more common, yeah. And bilateral cases are pretty frequent, 20 to maybe 80%, though that upper range is debated. It's definitely something to check both hips for.
And incidence is rising. Linked to obesity.
That seems to be the trend, unfortunately. And it's important to remember it can be missed, especially maybe in girls or with atypical presentations. It's one of the most common adolescent hip problems overall.
Okay. Now, clinical features. How does the patient actually present? We have another mnemonic here. Painful limp with outward rotation and knee pain.
Yes, another good one. So pain is usually the main complaint. Hip pain, groin pain. Or that referred knee pain. Crucial not to get sidetracked by the knee. Always examine the hip in a child with knee pain.
Absolutely. Classic pitfall.
Then limp.
Limping. Very common. The gait is altered because of the pain and the mechanical issue.
Makes sense. And the key physical sign.
Outward rotation of the affected leg.
Yeah.
When they're lying down or sometimes when they walk, the foot on the affected side points outwards more.
That external rotation is a big clue.
It really is. You'll also often find decreased hip motion, especially internal rotation when the hip is flexed. That's a sensitive sign.
Limited internal rotation and flexion. Got it. And the onset. Can be sudden or gradual. Yeah, it varies. Can be insidious, chronic, just a mild ache and limp for weeks or months. Or it can be acute, maybe after minor trauma, with severe pain and inability to walk. or that acute on chronic picture we mentioned.
Right. And sometimes leg length discrepancy or muscle wasting.
Yes, especially in more chronic cases, you might see some shortening or atrophy on the affected side.
Okay, so suspicion is high based on history and exam. What investigations confirm it?
X-rays are the mainstay. You need good quality AP, anterior, posterior, and frog leg lateral views of both hip.
For both hips, always.
Always compare. You're looking for that displacement of the femoral head relative to the neck. Early signs can be subtle, maybe just some widening of the physis or some fuzziness.
And that line, Klein's line.
Exactly, Klein's line. On the AP view, you draw a line along the top edge of the femoral neck. Normally, it should intersect part of the femoral head. In SUFE, the head slips down, so the line might intersect less of the head or none at all. That's a key sign, especially in mild slips.
Okay, X-rays are key. Ultrasound, CT.
Ultrasound isn't standard for diagnosis, maybe could show an effusion. CT isn't usually needed for diagnosis either, but might be used for complex cases or surgical planning, perhaps to assess the 3D deformity better.
So X-ray usually seals the diagnosis. Management, what happens next?
Immediate referral to orthopedics is crucial. As soon as you suspect SUE, the patient needs to be made non-weight-bearing on that leg. Stop walking on it immediately.
Stop the slip getting worse.
Precisely. Avoid forceful movements. And the definitive treatment is surgery. The goal is to stabilize the epiphysis and prevent further slippage.
And how is that done surgically?
The most common method, especially for stable slips, is in situ fixation with a single screw. It's usually minimally invasive. They place a screw across the growth plate to hold the head in its current position.
Pinning it in place.
Essentially, yes. For more severe slips, or maybe some acute slips, sometimes an open reduction is done. That means surgically repositioning the head closer to its normal alignment before fixing it, maybe involving an osteotomy cutting and realigning the bone to correct deformity and hopefully reduce the risk of impingement later.
FAI, femoroacetabular impingement.
Okay. Yeah. But closed reduction, trying to manipulate it back without surgery and putting kids in spica casts, those aren't really recommended anymore. Higher risk of complications like AVN.
Okay, so non-weight bearing immediately, then surgical fixation, usually with a screw.
Yeah.
What's the prognosis? How do these kids do long term?
It really varies. Depends heavily on how severe the slip was initially, how quickly it was diagnosed and treated.
Early diagnosis helps.
Massively. Mild to moderate slips caught early and stabilized properly generally have a pretty good outcome. More severe slips have a higher chance of problems down the line.
Like what kind of problems? Complications?
Yeah. The big ones to worry about are vascular necrosis, AVN, of the femoral head. That's the most feared one, especially with unstable slips. Loss of blood supply.
Right. Also, hip joint incongruity, the ball and socket don't fit well anymore. Femoroacetabular impingement, FAI, where abnormal contact occurs during movement, leading to pain and damage.
And FAI can lead to
Early onset osteoarthritis, arthritis developing much younger than usual. You can also get leg length discrepancy, chondrolysis, which is a rapid breakdown of the joint cartilage, quite nasty, and there's a risk of recurrence or progression of the slip, though less common after fixation.
So quite a list of potential long-term issues if things don't go well or the slip was severe.
Yes, which really underscores the importance of prompt diagnosis and appropriate management. Getting FAI sorted out if it develops is also key for better long-term function. But overall, with good treatment, especially for milder slips, the long-term prognosis can still be good. Regular follow-up is definitely needed, though.
Okay, so to wrap things up, key takeaways for SCFE.
All right, remember, SCFE is that adolescent hip condition where the femoral head slips at the growth plate. Think risk factors: obese hormonal growing pain, obesity, boys, endocrine, earlier history, septic arthritis, hormones, older age, rapid growth, mechanical, opposite hip, nutrition, age, low height, growing, pain triggers.
Got it.
And clinical picture: painful limp with outward rotation and knee pain. Don't forget that preferred knee pain.
Crucial point, diagnosis.
Primarily X-rays, AP, and frog leg lateral of both hips. Look for Klein's line.
Management.
Non-weight bearing immediately. Urgent orthoreferral. Surgical stabilization, usually single screw in situ fixation.
And main complications to watch for.
AVN, FAI, early osteoarthritis, chondrolysis, leg length discrepancy.
Excellent summary. So the message is keep SUFE high on your differential for any adolescent with hip, groin, or knee pain and a limp.
Absolutely. Catching it early makes a huge difference. As you review this, maybe think about how you'd apply it in a clinical scenario or an exam station.
Good advice. And a final thought, perhaps. given that rising obesity trend we mentioned. Yeah, how might that continue to impact SUFE incidence? And will it change how we approach prevention or even treatment strategies in the future? Definitely food for thought.
It certainly is. Now, for anyone wanting to dive deeper or prep for the MSRA.
Yeah, definitely check out PASSMSRA.com. That's PASSTHEMSRA.com.
And also freemsra.com.
And freemsra.com. FREEMSRA.com. Both have loads of great resources.
Fantastic. Well, thanks for joining us on this deep dive into slipped upper femoral epiphysis. Hope it was helpful.